Do you ever wonder about all the things that can impact your fertility? Well, today we're going to talk about one of those things. And it's something that can not just impact your fertility, but could also cause you so many problems and pain. And that is endometriosis. It is such a difficult problem and so hard to diagnose. And so it's really important that you understand the signs, the symptoms, and the treatment. So today I'm going to introduce you to a specialist who's going to explain it all to you and help you advocate for yourself. You're really going to love this episode. So let's dive in. From our Building Your Family community, this is the Building Your Family podcast. I'm your host, Lisa Schumann, author, researcher, and reproductive medicine therapist. As the leading destination for support and education for people using reproductive medicine to grow their families, we cut through the noise to provide you with research-based information, effective and actionable strategies, and the support that you need to feel better so you can get into the driver's seat of your life and build the family of your dreams. We look forward to seeing you inside. Welcome back to another episode of the Building Your Family podcast. I'm so excited to have you here and today talk to you about an issue that is so prevalent. Millions of people deal with it, and yet there's so much mystery around it and so many misconceptions. So many people don't understand what it's about and get misdiagnosed. And so I think it's really important for people to understand the truth. And so today I'm going to bring you the truth from an expert. Her name is Dr. Jessica Ryniec. And she is a board-certified doctor in obstetrics and gynecology, as well as reproductive endocrinology and infertility. She joined CCRM in Boston in 2020. And in addition to presenting her research at prestigious medical conferences, Dr. Ryniec has authored several publications for notable peer-reviewed journals, including the American Journal of Obstetrics and Gynecology, and has done so many things with her career. But she's a true expert, as you will see here and on her platform on social media. She really has such a depth of knowledge, and I'm so grateful to have her here. Thank you so much for coming, Dr. Ryniec.
Yeah, thank you so much for having me. And I'm glad that we're finally talking. You know, we've been talking a lot offline and through social media over time. And so really excited to finally be sitting down and chatting with you.
Oh, well, thank you so much. And, I'm always so happy to see your face in person at ASRM or see you online, and you do so much for patients. And I know today we're going to really help patients with this tough subject. You know, it's been on my mind for a really long time. Some time ago, I interviewed Tara Lipinski, and she was saying that she felt that her pain in her backside was because she's practiced so many times and fallen so many times, and that she really believed that that's what it was about. And here's this person who was the first person to do this triple axel. And so you would imagine she's fallen many times. And of course, people thought, oh, I'm sure that's what it is. But then she finds out it's endometriosis. And you hear these stories about it being all over the body and people having so many different difficulties because of it. And so I'm really grateful that you're going to talk about this. And I thought we could start by talking about maybe starting with 5 tips that people can think about, or 5 facts that people can understand, so they can at least start to think about the pillars of information that will be helpful.
Yeah, absolutely. And I think the Tara Lipinski story is a great place to start. Endometriosis is really common in those assigned female at birth, but it is vastly underdiagnosed. And, you know, part of that is because symptoms can really vary on what you would expect for endometriosis symptoms. Part of it comes from, I think a belief or something that's pushed about, painful periods is normal, or, oh, you were a performance athlete, like the pain you're having is related to that and not to something else. I think kind of just an unfortunate history of, those of us with ovaries being kind of ignored over time when we have complaints brought to our doctor. And so, that really would be where I would start, that first of all, you're not alone. And second of all, it can be really hard to get this diagnosis despite it being so common. And it's really like 1 in 8 to 1 in 10 people with ovaries experience endometriosis, but it can take up to 8 years to get a diagnosis.
My gosh. And why is that so difficult? Why don't people understand what they have? Why aren't they diagnosed earlier? Why are their symptoms kind of pushed aside? Because I think most of us feel like that, right? We feel like, we just have period pain. That's it.
I think part of it is probably shame around talking about our cycles in general, like stigma and taboo about talking about women's issues, a lack of training in the medical field to deal specifically with endometriosis and think about more kind of subtle signs of endometriosis, and, probably just a long-standing history of kind of ignoring this pain as, this is normal. You're supposed to feel pain during your cycles, when in reality, there can for sure be like a degree of cramping and pain that people experience and have it not be endometriosis. But it's those people that we're seeing again and again with these painful periods or other symptoms like non-specific GI symptoms that get worse with your cycle, or, pain with intercourse or deep penetration, rectal pain with bowel movements, kind of these other more subtle signs that kind of scream endometriosis, but not necessarily every provider is attuned to look for. And I think that over time, people who seek out care and are, kind of brushed off as this is normal, learn to just not seek care anymore.
Such a shame. It's
Yeah.
such a shame.
Yeah.
And so, how do people know? How do we even understand this, or how do we know that we have it?
And this leads into one of the other points, is that diagnosing endometriosis, it's a bit tricky. And it's because it can present very differently. Like as a fertility provider, I'm seeing a lot of patients that have infertility related to endometriosis who are otherwise considered like silent endometriosis. To me, fertility is like a screaming symptom, but they're not having the painful periods. They don't have other GI symptoms. They don't have, pelvic floor dysfunction or anything. They are having a hard time getting pregnant, and that can be related to endo. Diagnosing it can be really difficult. The number of people even I see who, we go through fertility treatment and then discover endometriosis later on is higher than I would, like it to be.
Wow.
And that's because truly the only way to fully diagnose it is with a surgery where you look inside someone's abdomen and pelvis and see endometriosis and remove it and, get confirmation. There are certainly signs of it potentially on ultrasound and MRI, but someone can have a totally normal ultrasound or MRI and still have endo. Obviously the symptoms, so the clinical picture can align with endometriosis. There are some newer tests that are kind of proposing to look at inflammation related to endometriosis. So one that I see in the fertility setting is a test called Receptiva DX, that basically it's a biopsy of the lining of the uterus that looks for a specific protein that's abnormal in inflammation, which again doesn't specifically diagnose endo, but is kind of associated with endo. Test isn't perfect. So, really the gold standard is surgery. And a lot of people would prefer not to have to do surgery to get a diagnosis. So a lot of times it's presumed that someone has it.
And so then how do we move forward? And what do you recommend to patients? Because if they say, well, I just want to start with IVF and everything looks okay, but then they're kind of risking maybe not having implantation, or maybe continuing having more endometriosis, right? It could keep growing and they can have other issues. So how does someone solve for that?
It's another really good point on my list of 5 things. You're flowing right into things, which is great.
Okay.
Treatment, it's very individualized, and it should very much be personalized to the individual, because the same treatment option or course for endometriosis is not necessarily the same between different people. I would say a lot of it depends on the age of the patient. It depends on the rest of their history. It depends on their full testing. So, if they have a partner with sperm, if there's any male factor that needs to be considered from a treatment standpoint. ovarian reserve, which is egg count, can play into it.
Hmm.
Oftentimes, if it is a younger patient with a reassuring ovarian reserve, no other real barriers to becoming pregnant, lower level interventions can be prioritized because there is a little bit more time there. And those are more likely to be successful potentially in those settings. And sometimes for younger patients with a high reserve, surgery could be a first step in treatment, and then either trying to conceive afterwards or doing kind of IUI and hormonal treatments before getting the IVF. Whereas if someone is older or has a lower reserve, or there's another reason for assisted reproduction like IVF, it may make more sense to kind of go more directly towards IVF and make embryos and then potentially treat the endometriosis on the back end before doing a transfer.
Hmm.
Or sometimes I'll have people that, like, again, we have no signs or reasons to think about endometriosis for them. And we do go through either IUI treatment that ends up being unsuccessful or IVF. And then we get through transfers that are not successful as well. And we end up kind of treating it from the back end of that too, which is never the ideal pathway. I wish we knew kind of ahead of time going into it what's going to be the most successful thing for people, but it's always, a balance of interventions and, trying to get you to the most successful thing sooner, but also like exposing you to the least amount of risk and least amount of invasiveness.
You know what? I love what you're saying because I think it's so hard for patients to think ahead the way that you're thinking ahead. They think, oh, well, I just want to start with the least invasive first. They're not thinking, well, I'm 37 or 38, and maybe I shouldn't be thinking that way. Maybe I shouldn't be thinking, well, I just want to try it home with Clomid and then maybe some IUI in a year from now. And then, maybe they should be thinking this way and thinking, well, I can deal with the endometriosis later, but I can only grab some healthy eggs now. So I love what you're saying because I'm sure that helps so many of your patients kind of rejigger the way that they're thinking about treatment.
Yeah, it's tough because everybody that comes to see me wants to be pregnant yesterday, right? Well, not
Yes.
everybody. Some people are coming for other reasons like fertility preservation and things like that. But, I see a big part of my job as framing to them how can we best reach their overall family building goal. So it's not always just about getting to this baby as quickly as possible. It's also thinking, okay, I want to have 2 or 3 children. How are we going to maximize these outcomes? Now that you're already here seeing a specialist like me, it didn't work on your own. How can we now maximize the information we have to help you get your dream family?
It's fascinating and so helpful, really so helpful because when you're in it and you're a patient who's really anxious, you're only kind of thinking in these narrow terms.
Hmm.
And, likewise, what we were starting to talk about before with a lot of the lesbian or single moms to be I see, it's also hard to kind of think beyond I need sperm. And if I have difficulty with home insemination, then maybe I'll use IUI. And then IVF is taking out the big guns. So I want to think about that later. But there's probably not going to be anything wrong with me because I just need that sperm.
Yeah, absolutely. And that's definitely something a lot of that population will come to me like, okay, well, we're going to correct my issues by putting sperm in the right place at the right time, which is, definitely the case a lot of the time. But 1 in 10 assigned female at birth does include the LGBTQ population. And that is whether someone is going to be doing inseminations or reciprocal IVF. It includes gestational carriers, although, typically a gestational carrier is someone with proven fertility and pregnancy history. So maybe a little bit less that, but, endometriosis does not discriminate.
Imagine your beautiful future. You're snuggling with your child. You feel so connected to them. Your friends and family are so happy, and you have everything that you've ever wanted. I want this for you too, but I want more than that. I want you to feel secure knowing that you've made the best decisions, not just short term, but long term for your future family. Wherever you are on your journey, whether you're choosing a donor, choosing a clinic, learning how to talk to your donor conceived child about their origins, All of these decisions will have wider implications for your future. And I want you to have the right resources so you can feel empowered and confident at this very important time in your life. That's why I'm so excited to introduce you to Building Your Family. It's the only expert-guided platform designed for parents and parents-to-be using reproductive medicine. We provide unique strategies that you won't find anywhere else to make your path to parenthood smoother and more informed. And that's why our approach is about offering practical and actionable steps that you can use right now. Whether you're just starting out or already deep into your process, Building Your Family is here to guide you with expert advice, specialized education, stress reduction strategies, and a community to support you every step of the way. We can't wait to see you inside. Just as an aside, I know we're off topic a little bit, and we'll get back to more topics. But let's say you see a gestational carrier's information and you're trying to clear them for treatment, and you see, well, yes, maybe they've had a successful pregnancy, but maybe there's been some endometriosis in the past. Do you worry, well, maybe it grew back and I have to look again? Or do you have concerns about that?
Yeah, I think if there were a specific history of painful periods or if known endometriosis and then subsequent fertility, it would be something that would give me kind of pause from a medical evaluation of a GC. I don't think necessarily it would make me rule someone out. I think it just depends on kind of their whole presentation and picture and like what's been going on in the meantime. If there's any really concerning signs like on ultrasound, endometriosis sometimes goes hand in hand with another common condition called adenomyosis, which, not enough time to talk about it all today, but that I would kind of keep an eye out for in gestational carriers that have prior fertility and a history of endo. So, yeah, I mean, definitely something to kind of think about. And, we do kind of a full medical and GYN and obstetrical clearance on these patients. So, would certainly give me pause if I thought there was a significant concern there.
Mm-hmm. So it could happen because I think one of the myths out there is that, well, if you get pregnant and deliver, you don't have to worry about it.
Yeah. I mean, I would say that's definitely a good sign and puts you kind of in a better prognosis. But, endometriosis, unfortunately, is progressive over time. And so, had someone had surgery and full treatment of endometriosis and then had a delivery, but then weren't treating anything in the meantime, suppressing with hormones or however you would want to treat it in between, that can progress. It can come back. Surgery is unfortunately not a cure for most people with endometriosis.
It's such a shame.
Mm-hmm. It is one of the top things that I wish I never had to see ever again. I wish it was something that we could really kind of cure and get rid of, but unfortunately, I don't know that is anywhere soon.
Yeah. And what else do we need to know about it?
Another thing to know would be that your degree of symptoms of endometriosis or even your stage, if you've had surgery for endometriosis, doesn't necessarily lead one-to-one to fertility troubles. And I say this because I will see patients frequently that have had surgery for endometriosis and they say, oh, well, it's only stage 1 or it's just stage 1 or 2. And a lot of times I think they feel really invalidated because maybe they've had like severely horrendous periods. And then, you hear there's this staging and grading and like you're one of like minimal or mild anatomically or, pathologically, but that doesn't mean necessarily that that's what you're going to experience for pain symptoms or fertility symptoms. So stage 1 endometriosis can be the worst pain. It can cause the worst fertility issues, whereas stage 4 endometriosis may be completely asymptomatic, also tends to have fertility issues, but maybe not. And so there's no like prediction of what the experience might be based on those things. And this isn't to invalidate people with stage 4 that have serious issues, but it's more to validate the people that, are miserable and having a very difficult time that like, yes, endometriosis could still be the issue here, even though it's just stage 1.
And what is the difference then about the different stages? Could you explain that?
So the staging is surgical, and I'd have to look up exactly what like the different stages are. But basically, it's a range of findings that you would see on surgery. And so stage one would be kind of more like smaller implants, less frequent implants or a smaller number of implants.
Mm,
Typically not having a high degree of scarring, with a minimal, where all the way to stage four would be more kind of major scarring, like what's called a frozen pelvis, where like the organs in the pelvis aren't really moving amongst each other. Large ovarian cysts that are made of endometriosis. So kind of a more of an anatomical impact. But depending on where the implants are for stage one, if you have an implant on your pelvic nerve, that's going to be exquisitely painful. Whereas if you have like a totally frozen pelvis, maybe like it was extremely painful when all of that inflammation was happening. But now that it's kind of more just scar tissue sitting there, it doesn't bother you. Again, that is not kind of universal. Anyone
right.
with any degree or stage can have different symptoms, but it's not, an exact kind of pathway from one to the other.
And it can travel all over your body, right?
They can. Yep. Most notably in other places in your abdomen. So like on the diaphragm and things like that. But realistically, endometriosis can be found at very distant sites as well. And that, goes to the theories behind how endometriosis kind of develops, which are a little bit complicated, but it's not just the menstrual cycle backing out through the fallopian tubes. There's other kind of complicated ways that it can travel.
And so as you're looking for it, you have to kind of, I guess, look everywhere. And I suspect from what you're saying, if it's a higher stage, then you probably have to look further because there may be a chance that there's more in other places.
Further implants. Yeah. Yep.
Wow, it's such a tough situation for people to have to deal with.
hmm hmm And it can impact fertility in many different ways, which is why we can't totally predict. And this is another point. There could be anatomical distortion. So it can block
Mm,
the fallopian tubes, or sometimes I've seen it like totally encase an ovary where the tubes are open, but there's like complete like scar tissue between the ovary and the tube. So the tube could never pick up the egg.
wow.
Certainly kind of endometriosis cysts in the ovaries can impact the quality of eggs, can impact the number of eggs, and then just the inflammation in general can impact egg quality, implantation, even sperm transport, and the way that the tubes kind of function. So there's a lot of different ways that it can impact your fertility, which really leads to another point here, that even though someone may have endometriosis and not have any issues trying to conceive or getting pregnant, it is one of those things that as a fertility doctor, I do want to see someone sooner rather than later. If they know that they have endometriosis, I would love to do a consult about egg freezing or embryo freezing. Or if they know that they have endometriosis or even suspect that they have it, I don't want them to wait the 6 to 12 months before seeing, because
Mm.
there's a higher likelihood that they will have, difficulty. And that doesn't mean that they can't try to conceive in the meantime, but kind of getting a baseline and seeing where things are at and making sure, again, we're optimizing that path to your, goal family.
That's so interesting. It seems like there's so many impediments to this idea that we should wait 6 to 12 months before we pursue it. And I would imagine that lots of patients probably feel like, it's kind of like across the board, it covers everybody. So no matter who you are, how painful your periods are, what your situation is, how old you are, you should just be waiting 6 months or at least.
Yeah, and I think that's general healthcare providers like primary care, and even some OBGYNs will kind of tell people like this is, the rule. They won't see you until then. I don't think I know a single fertility doctor that wouldn't be happy to see someone sooner than that. Certainly, in states with an insurance mandate like Massachusetts, where I practice, there are some kind of insurance restrictions around timing. So they do have those kind of, if you're under 35, over a year; if you're over 35, 6 months. But, those endometriosis is one of those reasons why you can kind of bypass that. Endometriosis, having irregular periods, suspected male factor, like those are all reasons why someone comes earlier. And again, I don't know a single fertility doctor that would turn anyone away if they're concerned.
So even if someone has irregular periods and a little bit of cramping and they feel like, well, maybe it's not a big deal, it's still probably a good idea to check it out before they start.
Yeah, I think so. I'm probably a little bit biased and skewed in what I see compared to like people who have no problem whatsoever. And that's why I say, while you're pursuing an evaluation, you try because you never know. And again, you might have no problems whatsoever. And seeing a fertility doctor doesn't mean that you need to have fertility treatment. It's basically kind of a checkup of where things stand and identifying any reason or cause behind more difficult time trying to conceive. But sometimes it's just reassurance that everything looks good. It's preconception counseling and okay, bye. I hope I never see you again. You've been
Mhm.
lovely. But if you get pregnant, that's great. Or I'm here for you if you get to the point where you need a little bit more.
And also, just to that point, Dr. Ryniec, I think it's so important for everybody else out there to listen to what you were saying earlier about kind of thinking ahead, because even if for whatever reason there's scar tissue or some reason why there might be difficulty, but somebody goes home and gets pregnant anyway, it doesn't mean it's going to happen for baby number two, either because they're older or maybe there's more endometriosis by then, right?
Yeah, absolutely. So each pregnancy and each try to become pregnant is different. And so those same kind of rules or those same, guidelines kind of apply. And again, you could get evaluated again and everything be fine and you go on and get pregnant, or things have maybe changed over time, either with age or with more inflammation from endometriosis that at that point you do kind of cross that threshold into having it be more difficult and needing some kind of additional treatment.
And are there things that people can do? Because you mentioned inflammation, and I know that's such a hot topic these days,
Hmm.
right? Everybody's talking about it. And so maybe you could talk to us a little bit about that. And I think what's also so important is kind of weighing that with the ovarian aging issue, because I think it's very natural that people are stressed about their eggs getting old, and very often there's a lot of denial around it and a lot of anxiety, and everybody wants to just stop eating cheese or whatever and
Yep.
say, okay, that's now I'm going to get pregnant, or eat a extra pineapple today or whatever.
Hmm.
Everybody wants to do that. Nobody wants to think about ovarian aging. And yet, I think that very often on the internet, people will do that, right? They're going to grab onto this. So, how can you help us balance both of those ideas, and also kind of think about the endometriosis and how to, if there's anything we can do about that as well?
Sure. Yeah. And lifestyle and kind of adjunctive things are important in endometriosis care, both from kind of an overall quality of life standpoint and a fertility standpoint. I am not someone who is typically like a big pusher of kind of like supplements and things like that. So, it really is kind of an overall healthy diet and lifestyle and doing things that are kind of more supportive of your fertility. And if you are kind of a more inflamed person or you have endometriosis, kind of targeting that. I try to walk the line and balance because you have to live life and enjoy life with infertility or live life and enjoy life with endometriosis. And so, you know, for me, it's not usually like cut out all dairy, cut out all gluten. If you are someone who eats gluten or dairy and feels really crummy and really inflamed afterwards, then yes, maybe those foods are not for you. But it's not kind of a universal thing to me. Things that are often overlooked: getting enough sleep,
Hmm.
drinking lots of water. I think those are two that like I usually find a big kind of bang for an intervention with those couple of things. So trying to get 7 to 9 hours of sleep a night. I know like almost no adults are actually getting that
Hmm.
because we're all like go, go, go. Drinking lots of water. So at least 8 cups a day. typically would recommend even more than that, but trying to get in your fluids. Stress management in general, again, like life is stressful, work is stressful, but trying to find outlets for stress. To be clear, like stress does not cause infertility,
Right.
but trying to find ways to kind of balance overall kind of mindset and having an outlet for things. And then from a diet perspective, trying to focus on overall like whole foods, avoiding kind of more processed foods when possible, red meat, kind of trying to limit red meat protein, focusing on some kind of more plant-based proteins, fish with omega 3s is really beneficial. From a supplement standpoint, particularly for endo, omega 3 fatty acids can be really helpful. And yeah, I mean, there's other things, moving your body, exercise, 150 minutes a week of kind of some more moderate exercise, which sounds like a lot, but actually kind of translates more to like 20 to 30 minutes of something a day, like walking. If you do more activity, you might like not have to do it every day, but moving your body. And I'm a big fan of acupuncture, not a whole lot of like solid scientific evidence to support, again, kind of like a one-to-one pathway, but if someone is a fan and enjoys that time, might be kind of just like a mindset and outlet for stress. But, I've had a few patients that are like really benefited from doing acupuncture for whatever reason.
Well, do you think it might increase blood flow? And a lot of people feel that way.
Yeah, that's definitely one of the proposed benefits. And,
Hmm.
I think it's probably more complex than that, but I always support a patient that wants to pursue that. I also support a patient who tells me, like, oh my God, I hate needles and it's so expensive and I just lie there and I hate every second of it, not
Hmm.
doing it. But, for those that enjoy it, I'm a pretty big fan.
So, just to kind of go back to the sleeping issue, I know people always wonder about that. Can you tell us why that's so helpful?
Sleeping just in general is, I think, more important than we think it is. It regulates a lot of our body's systems, and I'm definitely not a sleep medicine provider. And I know that I do not take my own advice, but,
Mhm.
your circadian rhythm, the amount of sleep you get, can impact the communication between your brain and your ovaries. It can impact like the overall level of kind of like inflammation and stress hormones in your body. So, kind of trying to aim for that like 7 to 9 hours is really kind of the ideal window when you talk to sleep medicine specialists.
And the same thing with drinking a lot of water, is it similar?
Yeah.
So we're really trying to kind of support the ovaries with that. And then what about the endometriosis or kind of like uterine health specifically? Is that about inflammation or are there other things that are helpful?
Yeah, I mean, I would say it's probably mostly from an inflammation standpoint. Certainly the good sleep and keeping the circadian rhythms can have a hormonal benefit. We know that people who are like reverse, so like night shift people can have a higher degree of infertility just because of shifts in the way that their hormonal patterns
Mm.
are working. So I do think that there's a little bit of an impact there on the ovary hormones as well, but I think just kind of overall promoting, a health and balance in your body so that, you can kind of control what you can.
And that is so important, right? Because so many patients, certainly, a lot of patients I've seen over the years feel so out of control. So if you have some of these things where you feel like, okay, well, I can do this thing and that thing and drink the water and try to eat a little bit less processed foods, maybe I can help myself a little bit more.
Yeah, I think that's so important because as you mentioned earlier, there's so much online and there's I think an immense amount of pressure that people with endometriosis or people with infertility or both like feel to have things in their control. And there's just so much about like microplastics and endocrine disruptors and,
Yes.
using all cast iron cooking. And, there's so much that we could do, but it's impossible to do it all. And so I try to, talk about these things that are more manageable, I think, for people. And then, trying to make subtle changes over time, like getting rid of plastic in the kitchen. Again, like I'm drinking out of a plastic water bottle as we speak. So, like,
Hmm.
there's no way to get it out completely. And I think, trying leads to more stress ultimately than
Yeah.
benefit. So it's kind of thinking about what you feel is in your control and deciding which things are kind of important and big for you. And I think, the sleep, the hydration, the kind of overall healthy diet, moving your body, that's kind of universal. And those are things that are pretty easily in our control. And then the other stuff, it's kind of deciding about like, what allows you to still kind of be functional and like live, but maybe try to make some like different choices.
Right. And also, I would assume that with the endometriosis, it's not something that people are causing either, just like people are not the cause of their infertility. They didn't bring this on themselves. It's not because they ate too many potato chips in high school or,
Absolutely.
whatever. And people worry about that,
Yeah,
right? They think I must have done something wrong, or if I'm healthy, then I should have perfect eggs. And if I'm have endometriosis, maybe I did something wrong. And then that of course leads to a lot of body shame and
absolutely.
feeling depressed and angry with yourself, and it just goes on, and it's so hard for people to really be kind to themselves when it comes to all of these things.
It really is. It really is. Everyone is always looking for how they did this to themselves, and it's not the case. Endometriosis doesn't come from you doing anything wrong. It is just there, and we don't totally understand where it comes from. Certainly more common in families and in certain populations, but we don't totally know. But it's definitely not like I did X and now I have endometriosis, or I did X and my endometriosis is worse than someone else's, or it's really complex and it's not the best understood thing, which is why, we don't get diagnoses, and that allows it to progress over time. And, there's just not as much in our control as we would hope.
So if it's in our family, it might be something that we have to watch out for.
Potentially, yeah. I mean, I would say for people who I see that, say their sister and their mom and their mom's sister, all had painful periods and endometriosis, or mom who had, a hysterectomy for pelvic pain and only had one child, those are kind of things that, perk my spidey senses that like endo
Mhm.
might be around.
So people really need to kind of think about that too. If it's in their family, they really should be cognizant of all that. And they may not have severe period pains or other issues and still have it, as you said,
Yeah.
anyway.
Just because your family has had a history of endometriosis doesn't mean necessarily you'll have any issues either. But, it's all kind of thinking about all of it and thinking about your specific menstrual history and symptoms, if any, and seeing if there was, something in the family, maybe it is more likely.
This is so helpful, Dr. Ryniec. Do you feel like there are other things that we're missing?
I mean, I think, we strayed away from kind of like the points, but I think we made most of the points that I was hoping to make. I think endometriosis is really complex and it's tough to diagnose, and it can impact people in so many different ways. So I feel like it's not the same disease in every person. But, I think if there's one takeaway, it would be that kind of advocating for yourself if you're concerned that you have endometriosis is really important. And that can be either in getting a diagnosis or in recognizing that you may have more difficulty getting pregnant if that's the goal. And so, kind of seeing someone sooner on in the process. Or, if you're not planning on trying to conceive anytime soon, doing some kind of fertility preservation. I think recognizing kind of what your goals are and, wondering if you have a higher likelihood of something like endometriosis, making sure you're advocating for yourself in those ways.
As you said before, also to think about that soon if you want to
Mhm.
have children, because it may be a long process, right? By the time you're diagnosed and have surgery, and then, who knows if it'll be complicated or not. There might be other issues to unravel, right?
Sure.
Well, this is all so helpful, Dr. Ryniec. Thank you so much for coming here and educating us. This is such an important topic. And I know there are a lot of women out there who have had regular periods and lots of pain and all sorts of things that they're worried about. And it's so helpful to know that there may be an answer to it. And I think that they can take more control in their life if they feel like there are things that they can do, right? So I really appreciate you sharing all of this great information with us.
Yeah, of course. And it was great chatting and such an important topic, like you said. I think, so misunderstood, so misdiagnosed and underdiagnosed. And, I think definitely becoming more prevalent in conversations lately. And so I think that's only a good thing, but, making sure we're kind of focusing on what we know and what we can do.
Yes. And you've given us some great tools today. So I think that, everyone out there has things to walk away with. So I really appreciate that. And tell me, where can people reach you?
So I am practicing at CCRM Fertility in Boston. We're in Chestnut Hill, so technically outside of Boston, but that's kind of our practice. And I also do a lot on social media, both TikTok and Instagram, and diving in a little bit to Facebook and YouTube lately. And it's Jessica Ryniec, MD, on all of those sites.
It's great. And for all of you out there who hasn't seen her videos yet, you will be amazed, interested, and also entertained, because they are really fun in addition to informative. So thank you so much for doing that too. I know it's a lot of work, and I think it's really valuable for everybody out there. So
Yeah,
thank you
thank
for your
you.
help.
Hopefully, people don't think I'm too crazy when they see my videos.
Oh, no, they're great. They're great. They're wonderful. I love them. So please reach Dr. Ryniec on social media or at CCRM. And thank you so much for coming. It's really helpful for us if you subscribe, because that's how we keep going. It's really important to us. I know there are a lot of people who tune in and they don't subscribe. So press that subscribe button before you sign off, and I will see you next week. Thank you for joining me today. I hope this was helpful to you. And if you'd like more personalized support, more information, and more education, you can find it in the show notes under the Building Your Family community. We'd love to see you inside. And if you were interested in today's topic, you will really like this video.